Kia ora koutou, everyone. I'd like to welcome you all here tonight to hear Jenny Carrier speak to us. I'm really quite excited to have Jenny come here because I'd heard very good things about some of her speaking in the past about a subject that's very dear to my heart, which is the health service, the health system, and the way it's working. And having had some involvement in PHOs in the past, I'm particularly interested in her interest in the way in which the system could better serve the underserved populations in the country, and the way that we could change health to be more focused on better health rather than the kind of health that we are experiencing at the moment, often at the front line, where we have very broken down sorts of processes of health, where you go along to see a doctor and you get one treatment for one thing, and it becomes very fragmented. So I was quite interested in hearing about the work that she'd done in this area. Jenny's got a distinguished background in the health system and in academia, and has a PhD in nursing and from Massey University. She's also served in many boards or advisory boards in the health system, and is currently still actively, even though she's part retired, still actively involved in many of these issues. So I'd like, without further ado, to welcome Jenny and look forward to your talk. Thanks.
I think I'm going to use this one because it gives me a little bit of flexibility. Yes, so thank you for the introduction. And yes, I am at Massey University, very, very part-time now, with just a few PhD students, and an honorary professorship now at Auckland University, in which I'm working in their Nurse Practitioner research program, which is one of the things I'd quite like to talk about this afternoon. And a lot of involvement over the past years with particularly policy engagement with the Ministry of Health. And for my sins, and it is for my sins, I've served on a lot of advisory boards and ministry working groups and government advisory groups, etc. And also was executive director of the New Zealand College of Nurses for 30 years, which was a wonderful way to stay very, very involved with health and with nursing practice, policy, politics, and professionalism. So I feel very privileged to have had a career in which I've had a foot in many, many camps and managed to have a very interesting and useful overview of the health system and how it works and how it doesn't work. Now I'm going to have to go to my bag and get my glasses because I cannot read my own slides without my glasses, and I never thought about that. So bear with. Thanks, Ellen. I suddenly realise I can't read a thing. I'll just grab them out. Oops. So, just to sum up about the health system, what our weaknesses are at the moment, which is a negative way to start, but it's a bit overwhelming at the moment. There are and always have been hugely different outcomes for people depending on their income, their ethnicity, where they live, and we're all incredibly aware of that. And the current health reforms are specifically aimed at trying to challenge and change that. We have a huge reliance in this country on internationally qualified nurses and doctors. You see there 36% now for nurses and 44% for doctors. And a lot of our politicians talk about the value of immigration and how it's going to solve our problems. But that is hardly ethical because we would be poaching staff from countries that are similarly challenged. There isn't a country in the world that can spare its own doctors and nurses. And for us to use our power as a nice place to live and the ability to pay reasonably well. It's just unethical. We have increasing challenges in providing care for older people. We're currently at least 1,400 nurses short in residential aged care. We have what I think is an outmoded model of private business general practice, which sits uncomfortably within our aspirations for accessible, equitable, community-based healthcare. And not to forget that our particular problem is that we are a very small country with a very small population, but we are spread over a country which is geographically quite challenging. People get caught in small towns with terrible weather. You can't get helicopters in, you can't get people out. We talk about the need to consolidate our services in particular areas, and economically that would make sense, but we cannot always guarantee in New Zealand that we can bring people from remote areas into those centres. And so that's a particular challenge for New Zealand. We have strengths as well, and unlike many countries, we do have largely free care for all, but a small copay, and it's not always that small, but a copay in primary care. There's always one who keeps their phone on, Helen. We have a non-litigious system, and that is of incalculable value. It changes behaviour when the potential exists to sue and be sued. And we actually score well on international comparisons around longevity, around health and wellbeing reports, and around the return we get on the investment in health. So there are some strengths, and it's not all bad. Our health system serves many people extremely well, in a very medicalised way, but it does. But increasingly we are now unable to do that, and we have this growing cohort of people whose needs are not met, and for some their needs have never been met. For a long time we've had particular goals in delivering health, and one of those for many, many years has been better integration between primary, secondary and tertiary care. People always experience falling in the cracks or huge duplication of services because there aren't appropriate connections between those particular aspects of the system. We need a much greater focus on wellness, as you alluded in your introduction. We remain hugely focused on the ambulance at the bottom of the hill. Not to say there hasn't been an enormous effort to change that, but as yet we haven't achieved that. We haven't successfully joined up the services between social care and health care. And for people with mental health issues, people with disabilities, for people who are ageing or who have long-term conditions, that connection between health care and social care is really important. We are trying to pay attention to advanced care planning. We know that as a system we spend a huge amount of money on people in the last year of their life, and that for many people that would not be their choice, or they would choose to spend it differently. And the answer to that is that people have an effective advanced care plan, but that system is a little bit rudimentary at this stage. The goal is to reduce investment in the last year of life, not to abandon people, but to change the focus of the investment in the last year of life. And I do know, I often get asked to speak to groups like Probus, for instance, and they're often very, very passionate about wanting to have control and autonomy over how and what sort of care they receive in that last year of life or as they get to end stage. We've had a long-standing struggle to implement a strategy that will embed primary health care and reduce our spending on hospital care. There's a long-standing statistic that about 40% of hospital admissions can probably be prevented with good primary health care. And that's an enormously enticing statistic, because if we really could prevent that 40% of admissions, we would have an enormous amount of money to invest in people's health and wellness and their well-being. and their ability to enjoy their lives. Everything I'm talking about has been, and more, has been identified, examined, talked about, written about, and debated at so many task forces, consultations, working groups, advisory groups. It just goes on and on and on. And I feel an enormous sense of despair when I think about the working groups I've been on, the amazing documents we've produced, the strategic goals those documents have had, and I think you could probably paper an office with those documents. And when you really look at them, very, very little substantive change has occurred. They're often not actually implemented, and if they are implemented, they're really very rarely evaluated. So some of that has to do with the ever-changing number of bureaucrats. And I have to say, I don't mean to sound negative and miserable, but when you go in and out of working groups in the ministry, you're faced with a constant change of faces of people who've just graduated, who've just arrived in the Ministry of Health, who do not want you to say, we've done that before, because that's a death knell. If you're a tall elderly and you say, we've done that before, you are never invited back to another working group. The truth of the matter is, however, we have done it before, and sometimes 2 and 3 times. And that's enormously frustrating, that there is a sense that the bureaucrats know best, and that the clinicians and the people who come to consult with them are just rather irritating people who they have to spend time with. Because essentially, we continue to do what we've always done. I mean, there's an enormous amount of tinkering around the edges, but the fundamental way in which we deliver our hospital services and our general practice services has not changed in multiple years. And the vested interests which work behind that are powerful, and medical hegemony is significant and very, very difficult to challenge. So in facing the future at the moment, and we know from media reports that the health workforce at the moment feels incredibly fragile and deeply stressed, and that people at the front line are working very, very, very hard and feel like they're only just hanging in there. And there are some opportunities to be seized. I'm not going to talk at great length, but artificial intelligence is with us and offers quite a big potential for change. It's already markedly superior than human beings for diagnosis of a number of conditions, and it offers unprecedented speed and scale of analysis, and it also offers us a number of really interesting ways to connect with people, not just artificial intelligence, but electronic communication itself. Lots and lots of services are using text messaging, reminders, and large sectors of the population find that useful and helpful. That should say virtual consults. People have mixed reports about the value of virtual consults. It's a convenience. It was really useful during the pandemic, but it isn't the perfect way to deal with people who've got complex comorbidities and really significant health challenges. It's useful for brief interventions, but the downside of, and there's voice-powered assistants too, but the downside of our adaptation of technology is that, of course, people may become more and more isolated. And we were having a conversation just before about the endless move to online learning at universities. I was saying that my husband, who's president of a bridge club, keeps bemoaning the fact that everybody wants to play online bridge and not turn up at the club. And this is and that's a phenomenon of that's with us now. The convenience of online activity is huge, but that's okay for those of us who are socially hugely connected, have many friends, and many other ways of meeting our need for social connection and human contact. Because if we rapidly move to technology and health, many people will become more isolated. And we know that loneliness is a really significant health problem. Some scholars have suggested that loneliness is as dangerous as smoking for our health. If we are to use electronic technology effectively, people need much better health literacy than they currently have. It's all very well for the worried middle class who read endlessly, who have very good health literacy and know exactly what they want. It doesn't work as well for people with really limited health literacy. And I worry, and I think I'm not alone, that disparities may well be exacerbated rather than resolved by the use of technology. It would be wrong at this point to talk about our challenges in health without acknowledging climate change and global warming, because that will be fundamental to health and to health systems. Clearly, we're seeing all around the world increasingly serious weather events. Extreme heat and extreme cold are health issues. When you see the figures of people who died, for instance, in Paris in the last heat wave, it is very significant. Obviously sea levels and flooding. I see just yesterday 2,000 people have been washed into the sea from Libya. Greece has lost quarter of its food production area is underwater. In New Zealand, we already have communities who are looking at being relocated, and we have huge dilemmas over who funds that and whose responsibility it is. Starvation is a real issue from droughts, and of course the other thing is that as the temperatures change around the world, the disease vectors change with the extension of tropical temperatures, and so we may start, here in New Zealand, facing tropical diseases that we haven't dealt with before. In order to go forward with the health system, we need to balance innovation with some degree of consolidation. And we need to think about the whole population, not just the well-off, the forceful and the articulate citizens who tend to be heard, who tend to step up and join boards and have influence. There are a number of really wicked problems that require solving in health. And I want to move now to talking about nursing, because that's my background, and I want to use it as a kind of case study of how we could do some things differently and why we haven't been as successful in doing those things differently. I've always seen nursing as a potentially transformative service if it was free to do as it would want to do. Nursing often gets trapped in contractual and employment issues that limit very much the way nurses can work. They're often working in significantly understaffed situations, which very much limits the quality of care. And they're not often the leaders of the service and able to determine the direction that service takes. And I want to use as a particular case study the role of nurse practitioner. We've seen a rapid increase in the number of nurse practitioners in New Zealand. There are now about 720. Nurse practitioners are registered nurses who've done a clinical master's degree and are regulated in a separate scope of practice, authorised by the Nursing Council of New Zealand. In that role, they have unrestricted independent prescribing. They practice without supervision or protocols. They are legally able to diagnose, treat, admit, and discharge. And most of our nurse practitioners are authorised in primary health care, aged care, mental health and palliative care. There are nurse practitioners in multiple areas, but the vast majority are particularly in primary health care and aged care. Now, if we look at this role in New Zealand, to produce a nurse practitioner costs approximately a sixth of the cost of a general practitioner to put in place. Their current salaries are often less than half that of a GP. This varies around the country, but where GPs are salaried, their salaries are usually at least twice that of a nurse practitioner. And yet, they provide exactly the same service. They are legally able to deliver exactly the same care. And the very interesting thing about this is that nurses are the only health workforce that remain well distributed in the country. There are nurses still in every small town, rural area across New Zealand, whereas physio, allied health, midwives, doctors have become almost non-existent in some of those places. So the potential to grow nurses in those really underserved small towns and rural areas into nurse practitioners is huge. What we know from emerging research in New Zealand and long confirmed research from overseas is that when patients are enrolled with a nurse practitioner, they express significant levels of satisfaction. And the things we find, and I've got a PhD student here in New Zealand who's surveyed 350 patients and interviewed about 30, is that patients who've received their care from a nurse practitioner instead of a general practitioner report that they have a much greater sense of knowing how to look after themselves. They feel much more comfortable asking questions. They feel much clearer about how to manage their care and their medication. They have an understanding of their condition and the relationship of the medication. And the clinical outcomes are equal or are very similar. There's no measurable difference in clinical outcomes between medicine and nurse practitioners. But those other soft things, which I think are really, really important for people who are ageing or have long-term conditions, etc., the ability to feel on top of your condition and able to manage is really, really important. One of my PhD students is studying a concept known as enablement, which is how much people feel able to go on living their lives well and manage the conditions that they have. Every year we allocate more money to general practice training, and every year it's actually underspent because medical students are not seeking out general practice as a career destination at the same levels that they used to. We've had a constant drive to encourage medical students into general practice, but we are extremely short of specialists. Every year we turn away applicants for nurse practitioner education because we don't have enough funding. And we run the current programs on a shoestring. The good news, since I wrote this slide just yesterday, is that last year we managed to double the funding from 50 places to 100. And today I found out that we've got 140 applicants for next year, and Te Whatu Ora has tentatively suggested that they will fund all of them, which is a huge breakthrough. Not confirmed yet, but clearly might happen. And that's really, really good news because it took us years to fight for the other increases, and this one appears to be coming more easily. So there is a sudden recognition that these people are critical to providing healthcare. So one of the barriers we have is what I refer to as medical hegemony. It's much easier to get investment in medical solutions to health problems. We see the health, as you alluded at the beginning, through a very medicalised lens. We also struggle with the issue that nursing is often seen as a cost to be pruned rather than a resource that warrants investment. And so if you're the chief executive of a large hospital and the budget's in deficit, as they almost always are, when they look at their bottom line, it's always nursing, because nursing is the largest health workforce. And regardless of how much we pay nurses, their sheer numbers mean that they are a huge part of the budget. And so they are often regarded by ignorant chief executives as the low-hanging fruit that can be pruned on the budget. And yet, we've got years and years of data showing that investing in registered nurses, in fact, Linda Aitken from the University of Pennsylvania did some work that showed that every extra dollar invested in registered nurses probably saved $14 in the reduction in adverse events, reduction in the length of stay, and reduction in the readmission rates to hospital. Now that's potentially a huge saving, but we still struggle to staff hospitals properly with registered nurses. And of course the downside of that is is that people are discharged early, they're discharged with unresolved problems, and they bounce back into hospital, and we're not developing the services in the community adequately to take care of those people. I think there is a way forward. I think nursing's done a huge amount of work in the last 20 years, changing the regulatory and educational capacity to produce nurses who have a very, very flexible scope of practice. I've talked about the nurse practitioner role. We've shown through research that postgraduate study really supports an advanced level of practice, not just in the nurse practitioner role, but for all registered nurses. And as I said before, it's worth remembering that nurses are distributed through rural areas and small towns where the unmet need is the greatest. And that's something we should be drawing on. We need a bit of a mind shift moving away from nursing now. Evidence shows us that clinical care contributes about 20% of health outcomes. And that what really makes the difference is the socioeconomic determinants, people's health literacy, the way that we partner with people for health. All of those things contributes probably 80% of health outcomes. And yet our whole focus and investment tends to go on medical solutions, not these other things. Because health is so much more than diagnosis and treatment. And we really need to defend that position in the face of the very powerful vested interests of the pharmaceutical industry and other vested interests in health. Sorry about that, slide's very pale. Just as a point of interest, there's a predicted shortage of 20 million health professionals by 2035, and it's already an obvious global problem. And so what that means is that we really need to be thinking incredibly critically about how we use the workforce that we've got. That's probably the single biggest challenge, and ironically, the area where we could make the biggest difference if we were able to do some things differently. So as I said a little while back, years and years have been wasted in the bureaucratic production of high-level workforce strategic documents. And what we've overlooked is the attention to what one of my PhD students, Rhonda McKelvey, calls the situated intelligence of those at the front line. This plays out very, very clearly in the issue around staffing in hospital wards. There's a system called Care Capacity Demand Measurement, which electronically measures the acuity of patients and matches that with the staff that you should have on the ward. But that data is never taken notice of because it immediately challenges the answers. When the nurses say, well, we are understaffed by 5 nurses, the answer is always, well, actually there's no budget for another 5 nurses, or we haven't got another 5 nurses. But we continue to rely on that data. It's also true that nurses absolutely believe that care capacity demand management doesn't accurately measure the work that's required. And so Rhonda McKelvey explored this notion of situated intelligence, which is that people who work day by day by day with patients at the front line deeply understand what is required. One of the other ways in which situated intelligence is disregarded is when new hospitals are built. And nurses will say to you, I knew that cupboard shouldn't be there because everybody's going to bang their head on it when they do this, that and the other. But the architects never speak to the nurses who are in and out of these buildings and places and moving beds and moving patients and trying to fit. And again, their situated intelligence is ignored and the buildings become cumbersome white elephants. Just want to move, I'm going to move sharply on now because I'm sure people would much rather talk. One of the things that really annoys me about health is that it is always a political football, not perhaps as much as law and order. National and Act have proposed the removal of Te Aka Whai Ora, that's the Māori Health Authority. I think that's an appalling backward step. Te Akawhai Ora has been in place for, I don't know, maybe 18 months. It's just becoming established. It is strongly supported by iwi and hapu leaders throughout the country. It's working very effectively in a partnership with the main health authority, Te Whatu Ora. It's very early days to judge its effectiveness, but we cannot talk about being a treaty-based country. We cannot talk about Māori self-determination and propose to simply knock away an establishment that Māori want in the face of the kind of health disparities that we have for Māori in this country. National have proposed that if they get into power, they'll build a new medical school. I cannot explain how appalling I think that is. Our academic workforce is very, very thin on the ground. Both Auckland and Otago have said they have capacity for more students. Yes, we do need to train more doctors. But can we afford to replicate a third medical school in a country with 5 million people, requiring that whole extra resources of laboratories and staff, etc.? They've also talked about the reintroduction of targets, and that makes me just shudder. Health targets, and I'll just put up here a small excerpt from a paper which I hope you can read. Can people read that? Yeah, so just read that quietly to yourself about targets. Do you need me to read it for the... Yes? Okay. Targets create measurement fixation, tunnel vision, myopia, ossification, anachronism, and quantification privileging, misplaced incentives and sanctions, complacency, silo creation, overcompensation, undercompensation, insensitivity, and increased inequality, breach of trust, misrepresentation, gaming, misinterpretation, bullying, erosion of trust, and reduced staff morale, and politicisation of performance systems, political grandstanding, and creating a diversion. Now that's a summary in the abstract of a paper which explored the consequences of implementing targets in a wide range of settings from the Journal of Internal Medicine. And I strongly relate to those statements in terms of seeing the impact that targets have had on staff who are struggling to deliver services when they are understaffed and under-resourced. So in summary, really, we do require some radical change. We need a much greater focus on demedicalising what we invest in and what we spend our time on. We need a much better use of the full range of the health team. Obviously, I've used nurse practitioners as a case study where we could, with a minor investment, make a huge difference to service delivery. But it's true for a whole range of people, particularly our unregulated caregivers, our mental health workers. I won't go on, but we tend to be locked into old ways of doing things and not to be particularly creative about how we use the full health team. And often that comes down to clumsy legislation barriers. Just as a point of interest, the Medicines Act, which legitimates nurse practitioners to prescribe in an unlimited fashion, well, in line with their clinical judgment, has a section in it called Section 29. And when the new Act was passed, someone forgot to change Section 29 in the Act. This was back in 2014. Section 29 lists a small number of drugs which can only be prescribed by a medical practitioner. Throughout the pandemic, many extra drugs have come into short supply and new drugs have had to be substituted. In addition, cannabis is listed under Section 29. We've been trying now since about 2016 to get Section 29 amended so that nurse practitioners can prescribe perfectly simple drugs which are only here because of required substitutions. And it's just deeply annoying that it takes so long to make these very simple bureaucratic changes. Yes, it is. It's absolutely with the ministry, yep. We need much greater involvement of clinical staff in decision making at all levels of health, and I would hope a serious review of the role of bureaucracy. I'm not suggesting we slash the bureaucracy. I have no idea whether we have too many or too few, and I don't think anyone knows whether we have too many or too few. But there is a lack of important connection between people at the front line and people who make bureaucratic decisions. And I think that's the end, and I'm now happy. I don't know what time we've got, Pat, but I'm really happy to just chat. Yeah? Cool. Cool.
Well, thank you very much. There's so many things that I'd like you to expand on, but
go on then.
I think we'll ask what people here want to know about first. And thank you for that sort of overview of the
yeah, it was a bit of a speed trip.
Yeah. But there were a few. I mean, I think if you'd like to just think about this, I'd like to. Oh, sorry. I'd like to understand more about what you've written about the role of the nurse practitioners, which is different from what we understand a doctor's role is. And I think that when I read what you were writing, I found it quite exciting, the idea that we could formulate that. But if we can't get through bureaucracy, then to have it happen, if we can't get through the bureaucracy, is there another way that we could actually start to, from the community level, demand these things? Because people don't really understand these things. That's one of the things. I'm not sure. I think I'd like to ask other people, and we'll come back to that later.
Because that's probably easier while I'm thinking about it. So just your first bit, what's the difference between a nurse practitioner and a doctor? The thing is that a nurse practitioner is legally able to deliver everything that a general practitioner can. There is no difference. But the point is they come through a Bachelor of Nursing, so their first education is as nurses. So they have the philosophical approach to practice of a nurse, and then during the master's degree they add a number of extra procedures, tools, prescribing, diagnosis, ordering diagnostic tests, etc. But they always practice as nurses foremost, but because they're nurse practitioners, they're able to provide the full episode of care to a wide range of people. But they do it through that nursing lens, and that what we're seeing patients really value. Unfortunately, most people in New Zealand still probably don't know what a nurse practitioner is. But what we find is that once people have been enrolled with and received their care from a nurse practitioner, they never want to go back. And this kind of sets up an uncomfortable adversarial stance with general practitioners who are also good people doing good work and who are also exhausted at the front line. But I kind of look at it as they are voting with their feet. Medical students are not selecting general practice in large numbers. They are very top-heavy in age-wise. Large numbers of them are very close to retirement. And so pragmatically, I am passionate about rapidly building the nurse practitioner workforce so that it's there for people. And I don't see it as adversarial at all. They're not going to stop training general practitioners. They're not going to stop. They're not going to take general practice money and give it to nursing. You can be very sure about that. Well, I don't think it'll come to that. We've got room for everybody. There are so many. There are now 1 in 4 practices in New Zealand have closed their books, and people can't enrol. So, and that's rising. It's not about a competition. It's about actually developing that service. And I do see a hugely increased willingness in Te Whatu Ora to support the investment in nurse practitioner education.
Okay, I'll hand over to people here that want to ask questions. Yeah.
Oh, sorry. Can I just ask a silly question? In terms of the nurse practitioners, I mean, I go to my local GP and they have a centre. Are there nurse practitioners operating there? I would have no idea.
No, well,
whereabouts are they?
well, they are in a great. There are about 720 in the country, so the practice you go to may or may not have a nurse practitioner, and you can only find out by asking or by looking at the board out the front. So there are practices that have 3 or 4 nurse practitioners. There are practices that have no nurse practitioners. So you can only ask. Things there.
Thank you very much, Jenny. You made a really good case of how over time, we've seen very little change when we think about what happens in a hospital environment and, in fact, across our healthcare system. But I think we are all very aware of that silent growth, and it is quite silent, of the increasing corporatisation of not only general practice, but pharmacy, and also the enormous growth within private hospitals and the scope of private hospitals. For example, I don't know if you would like to comment, but certainly some of the shortages that we see in radiology, for example, in hospitals, are a direct response to the increasing privatisation of cancer care and therapy that require radiology at a very, very high level. So within New Zealand, I think in the last 5 years, the number of private radiology services within communities has grown exponentially. Yeah. And this is having a direct impact. It's having a direct impact in Hawke's Bay at the moment, but who have lost their ability to train radiologists, and again in Dunedin that we've just heard of this last week. I'm wondering if you wanted to make a comment.
Well, I'm very aware of the situation you describe. I am also very aware that if we change government in October, that process will probably speed up considerably. I know that it's a political belief of the right that privatisation is a value. I don't support that at all. I think that creating a 2-tier system, we already have a slightly 2-tier system where if you're relatively well off and articulate and educated, you can manipulate the existing system to do well. And I think privatisation simply exacerbates that because it pulls resources and people into a comfortable, well-played area where you only see nice, well-off people who don't have very complex health problems. I think it's a very, very negative trend, but I don't know how you stop it. Well, we can try keeping the government we've got. I'm unashamedly political, but we have no control over that. Yeah.
You probably won't allow me to ask this question, Jenny. Sorry, that was such a fabulous summary. It's really excellent. Thank you. Te whata ora, I guess that takes 10 years for that process. Is that about the time scale that we're looking at?
Oh, I find that such a hard question. I would love to say yes. I'll tell you something that happened that really I found very, very dispiriting about that. One of the proposals of the health reforms is that we develop something called localities, which in many ways is another iteration of primary health organisations. And in many ways it's founded on the notion that local communities, I'm coming round to your question in a roundabout way, it's founded on the notion that communities know what they need and that communities need to have a high level of self-determination in developing what they're going to have. And there have been some test locality areas, one of them in particular, South Auckland, an area with huge disparities and health needs, has been very industriously working on planning what their locality would look like. And I read a very sobering report in the New Zealand Doctor magazine and I'm going to name the person because he's named in the New Zealand Doctor magazine, Danny Wu, who's a long-standing person I've known in the Ministry of Health, went to meet with the leaders of the South Auckland trial locality, and they presented with huge enthusiasm everything that they'd done and found. And he said, but it's actually not up to you to tell us how this is going to go. We're going to tell you how it's going to go. And I just found that probably the most depressing thing that I've read in a long time, because it's exactly what I was talking about, which is the ignorance, the ignoring of situated intelligence, and the kind of we know best. So will Te Whatu Ora be successful if they genuinely engage with people at the front line and genuinely listen and respond to the people who are out there doing it, and if they set up consultation mechanisms that allow them to hear what's happening? The structure, the fact that we don't now have multiple replications of everything around the country can only be a good thing. I intellectually support the notion of having a central health authority with a Māori partner. Absolutely support it. How it works will come down to the actual micro behaviours that go on within that organisation and its relationship to the wider community. That would be my simple answer.
Is there one? Can I ask you one more question?
Of course.
In that, in 2017. Sorry, that's the old days.
Yep.
2017, we made a film about a documentary about education and about art advisors and about ways of teaching. And one of the advisors, art advisors in that film said how things changed when the responsibility of the public service was to the children, how it then became to the minister.
Right,
I mean,
interesting. Yeah.
Really that's the key to change, isn't it?
Yep, it is.
It's to the people of New Zealand that we need to be.
Yep. And I always remember my son leaving school and finishing his master's degree, and the first job he got was with the Ministry of Social Welfare, and he spent a very happy year researching some youth health issues, and he was very excited about everything that he found and did, and then Paula Bennett literally ripped it up and said it conflicts out with our ideology, and he left the Ministry of Social Welfare and has never done that work again. And I think that sums it up. That's about the responsibility was to the minister, not to the people that the project was designed to serve. Yep.
Thank you very much.
And I guess that the other thing in there is that when the responsibility is to the minister, it's a cautionary process that you engage in. People start to become worried about anything that they might do that will actually not work. And so therefore we end up not being able to take any risks in what we do. Yeah.
And we are enormously risk averse.
Yeah.
It's true.
I must admit, I did notice a lot of what you've said is very much in this area. What we had in the PHO when we were working there, we spent a lot of time trying to bring the community in, but we were met with the difficulty of dealing with bureaucracy, but also the difficulty of expertise among doctors who didn't want to actually engage in these processes. You're very kind to doctors. I think a lot of them are very good and want to do.
I try.
But I did find there that when we were trying to set the PHO in a model that was going to try and work at best for the community, that at every turn, and you said somewhere that the PHOs became a management tool for the for the medical system, and that's exactly what we got trapped into. Every time you turned round, there was some part of the doctors, regional or local bureaucracy that was actually guiding what was going on and subverting it. And we found the most difficult thing was we tried to set up a wellness centre with not practitioners because they weren't around at the time, but people who were nursing to do things there, but there's no funding. The funding had to fit into moulds, and then the doctors fought against it because they saw it as undermining their financial situation.
That's right.
Yeah.
That's right.
And
that's exactly right. Yep.
Oh, that's all right. No.
I'm going to be a lamb in a lion's den because I'm a former practitioner, general practitioner, and
nice
a practice
to meet you.
owner. I would suggest that the scope of practice between a nurse practitioner and a GP are wildly different. Okay.
Tell me how.
It is a whole. If they were the same, you'd have the same education and training. I don't believe that's the case. And I'd like to just finish my bit before you.
Yeah. Go. No, I'm listening.
I would say the vast majority of general practice would agree with me. Not necessarily extremely. We have no antithesis towards nurse practitioners. There's a scope of practice which is part of general practice, which nurses that are highly trained can do, and I'm not against that. The problem is what happens is that nurse practitioners are not in spaces where general practitioners need help, like after hours, where that's where we get lots of children with minor conditions that nurse practitioners could sort through, but they're never there. The second thing is that the reason that primary care is failing is poor funding. There's a massive loss of funding. Thirdly, a 15-minute consultation for a GP is far too short. And if nurse practitioners are doing it in 15 minutes, I'll be amazed. And if you look at most of the nursing practices, nurse practitioners I've worked with, they're taking half an hour or more to do the same job, and it has a very limited scope. And finally, we are moving into a world of vicarious liability, which is a practice owner will be liable for mistakes made under their care, and that is now part of law.
Are you referring to this most recent case of
Yes,
Ryan versus the HDC?
Yes,
yeah, I know. I think it's really important that we have always previously understood a huge difference between vicarious liability and professional liability. They coexist. And that case absolutely was an unusual outcome because it suggested significant blurring between vicarious and professional liability. But at the end of the day, nurses, nurse practitioners and medical practitioners are regulated under the Health Practitioners Competency Assurance Act, and they are responsible for their own practice. And I don't actually believe that Ryan versus the HDC has changed that fundamental fact. So we're going to have to disagree about that. Yeah, it's a one-off case, and I'd like to understand it better. Even though I've read all of it, it doesn't make sense. Go on then, do.
If you really believe what you believe, and I accept that, and I don't even want to deny that you could be right. Why don't you set up a huge pilot study in one part of the country where you focus your nurse practitioners and substitute the GP's work, which are maybe shortages for nurses, and show those outcomes, and that would be a very powerful piece of information. We need then to understand what it is each are doing, because if you slice off the easy bit of general practice, then you are going to have very good outcomes. But if you give the complex bits of general practice to nurse practitioners, they will fail. They will get into huge problems, as GPs do.
Okay, so let me just answer that, because first of all, that research has been done numerous times, not in New Zealand, but in America and Canada, where they've had nurse practitioners who deliver care completely unsupervised for large populations and have done for 50 or 60 years. And numerous academics have measured the clinical and safety outcomes and found there to be no difference. There are already nurse practitioners who are working in practices where there isn't a GP for 100 kilometres in New Zealand, and nothing has gone wrong. There are concerns, as there are for all health professionals, get reported. The complaint industry has certainly increased enormously in the last 3 years, and all health practitioners have experienced more complaints to the HDC. But essentially, I think there is one case in New Zealand where a nurse practitioner has been found that her care was lacking. And yet there are many who are working where there is no GP anywhere nearby. So I think we have that evidence. And I understand how difficult it is to think, why would somebody do all of the medical education to do a role, and why would somebody do... the difference, the nurse practitioners have 5 years academic education and at least 4 years clinical practice experience. So it isn't as different as it seems on the face of it. But maybe if they can do, and this is a really challenging thing for me to say, but maybe if nurse practitioners can safely and effectively deliver that care with the education that they've had, then maybe we don't need what you have had to do the job. And I understand that's a really challenging and offensive thing for me to say, but when I talk about us needing to really think creatively and differently about the future, that's one of the things I'm thinking about. Do we need to say, just because we've always had and done that, do we always need to have and do that? And I don't know the answer, but it's how we have to start thinking in the future. Yeah.
I've got a question from someone who's in Gisborne and tuned into this session. And she asks, you've been talking about the front line who should be involved in designing, planning and implementing health services. Do you include consumers? Do you include patients, whānau, families in that front line?
Absolutely. And I think that is one area in which health has been very negligent. We often set up advisory groups and working groups, and we invite a token consumer onto that group. And it is very difficult to be a lone consumer on a working group that's populated with health professionals. It's a very isolated and lonely role, and it means that person's voice is often not clearly heard or responded to. So yeah, intellectually, I absolutely agree that we should have much more opportunity to listen to patients and consumers, and we don't do it well, would be my answer to that person in Gisborne.
I think if I could just make one comment about before, and it may seem a bit facile, but one of the things that I'd just like to raise here in a little way is that when I was working in international development, the Fred Hollows Foundation, if you remember, found a different way of doing some medical treatment. That didn't involve every year, ophthalmologists from here were going up to the Pacific for a spell of time and helping to fix people's eyes. And he found a way of training up local people to do simple tasks as part of the system. And I guess in a small way, I think that's maybe what we're trying to sort of search here in a little.
It's not what I'm talking about with nurse practitioners, but it certainly is in terms of using the full health team.
The full health team, yeah.
Absolutely.
So no, I realise with nurse practitioners that they're very highly skilled, but it's just a part of trying to see the medical system differently and to try and see if there are other ways to address the same problems in a different way. And I found personally that was one of the biggest things, was trying to see the new ideas come up, because people are so pressured in what they're doing at the moment that it's very difficult to lift your head up and see the bigger picture, that maybe things could be done differently. I think that's one of the...
You know, there's just a very interesting point. I've just been on a 2-year Health Research Council funded research project in which we got to travel all around the country interviewing the doctors, the nurses, the patients, the reception staff in general practices all over New Zealand, and we did it for corporate practices, traditionally owned practices, the whole range of models. And the brief for the research was to look at the models of care within those different ownership models. And what was really interesting is that there were enormous variations across the country, but it bore no relationship to the ownership model. It had everything to do with the individuals that were in the practice. So you could go to 2 practices that were completely differently owned and structured and funded and see or you could go to 2 that were similarly funded and owned and structured and see completely different ways of doing things, use of funding, use of the workforce. It was just a fascinating study with absolutely no conclusions at all, because the variations were so vast across the country. And we went to practices from Dunedin to Northland. Not just me personally, but the whole team. Yeah.
Well, there's so much to talk about in this area, and I guess that what I'd like to thank you for is just opening up the discussion about this. We've had a talk by Peter Crampton on where
Peter was on that research team as well.
Yes, and he was looking at what was wrong in the system and led up to the reforms. And then we've had Rob Campbell, yes.
Oh, really?
Rob Campbell, we had him come to speak about just at the point at which he lost the job.
Oh, right.
We had him come and speak, and I think that gave us a big insight to where things were at. But I think what we would really like to be doing more of is looking into what could be.
Yeah.
And I think that's really what you've given us a little insight into tonight. Thank you. So thanks. I'd like you all to thank Jenny for the... Okay, thank you.